Thank you for the presentation. Thank you for the organizer who allowed me to present you our results. We move back to pediatrics, very, very young children. And well, the challenge of optimal perfusion is, of course, tissue oxygenation. This, everybody agrees with this. And during the last decade, a lot of work has been done to demonstrate how important was the flow and how important was the oxygen transport, so DO2. And even it has been demonstrated that oxygen parameters were decreased when the flow was low, and this was regardless of the perfusion pressure. So really, everybody actually is focusing on flow and on DO2. Now, the perfusionist has to deal with an important question as competing hemodynamic priorities between organs during perfusion. That means the heart and several organs receive a better perfusion if the pressure is low, if the afterload is low, whereas brain and kidney, they will have a better perfusion if the perfusion pressure is high. And why this? Because they have autoregulation of their blood flow according to pressure. There has been a very good presentation this morning showing cerebral autoregulation. So maybe that the goal of perfusion is not only to maintain DO2, maybe perfusion pressure is also a good parameter to monitor. So I won't speak about cerebral autoregulation in adults. This has already been presented. So in children, we know that there is a lower limit of pressure below which this autoregulation mechanism is failing. So in 4-year-old children, this is about 40 millimeters of mercury. And in younger children, this transition is somewhere between 20 and 40. We don't know exactly which is the lower limit. What do we know about renal autoregulation on bypass? Not much. What we know is that in adults, again, if the perfusion pressure is below the cerebral autoregulation threshold, then those adults will be at risk of kidney injury. And also what we know is, this is from experimental work, that when the perfusion pressure gets very low, the renal autoregulation is impaired before the cerebral autoregulation is impaired. So that means the kidney will be sacrificed before the brain. So, kidney injury related to cardiac surgery in infants, of course, is multifactorial. We will especially focus today on ischemia reperfusion injury, but whatever the mechanism is, it has been demonstrated that everybody agrees that the initial lesion is the tubular injury. It's not glomerular injury. So that means it makes no sense of measuring kidney function after cardiac surgery using creatinine, which is the most widely used kidney marker. We need other markers, and we have other markers, lots of. Of course, I won't talk about all this. I will only focus on one, which is this one, the neutrophil gelatinase associated lipocalin. Very complicated name. We'll call it NGAL. And this is a previous work we did in Necker, where we studied this marker in 200 patients less than 1 year of age. And the majority had very low concentration in their urines. You see, we measured it very often. That means before bypass and until 2 days after bypass. There is a smaller group, 2 groups, which were very severe injuries, which most of them required dialysis, and those had very high concentrations. So we concluded that this marker was very good predictor of severe injury. Now, what is very interesting is to see that after bypass, within 1 hour after the end of bypass, there are already very different concentration in urines. That means something happened during bypass. And also, this concentration was already predictive of dialysis, and the threshold was of 21. So that means what happens during bypass is already predictive of what will happen in postoperative period. And with a diagnostic odd ratio of almost 10, this is a very good biomarker. So now we came back to this study of 200 patients. We couldn't analyze them all, and we had a look of what happened during bypass. So it was only 72 we were able to analyze, and well, we used the bypass parameters which were monitored using CDI system and which was stored using software which was provided by Sorin at that time. The target of the perfusion was SVO2 above 70%, hematocrit 30 during bypass and 40 afterwards. And we looked at these parameters: mean arterial pressure, DO2, and EO2. And the statistical analysis was very easy. It was just ROC methodology. So we had to define, first of all, what was normal pressure for age, knowing that normal pressure is very age-dependent. This is normal pressure in healthy children, aged from 0 to 1 year of age. We had to define which threshold we will analyze, and since during sleep pressure is 10% lower than awake, we thought we start analyzing a 30% or 40% for 50% drop from the age standardized normal pressure. And this is observed pressures in our population, so we already can see there has been many measurements which were below what is accepted, the lower limit. So now if you will look to one particular patient, exactly what we measured, this is his normal pressure. This is the threshold we defined. I only put 2 of them. This is his observed pressure, and what we measured was this area, which is the pressure time integral below the threshold. So we calculated for this threshold, we calculated for the next threshold, and finally, at the end, we had for each patient several pressure time integrals below threshold and we had the concentration by the end of bypass. That means it was very easy, starting with this, using the ROC methodology, and to understand which threshold was predictive of kidney injury by the end of bypass. We did this for pressure, we did this for DO2 and for EO2. So here are the results. This is a group with a high biomarker excretion, which is a group with a low biomarker excretion. So bypass times were quite usual, cross-clamping times normal, bypass temperature almost normothermic, arterial pressures were not very low, the flow, target flow, the DO2, SVO2, which was clearly above the threshold we fixed, the target, sorry, and EO2, which was very reasonably low. And of course, post-operative, this group had the dialysis requirement, whereas the other one didn't. So I just want you to observe that DO2 were reasonably high. In adults, there has been a work demonstrating that DO2 below 270 was predictive of postoperative kidney injury. You see, we're very much above 270. So this was quite reasonable. And now, this was the threshold we analyzed, and with this was the predictive ability of each threshold for kidney injury postoperatively. So what you observe here, it was mean arterial pressure drop was predictive, oxygen extraction ratio was predictive, but this was a very high threshold, and patient only spent seconds or very few minutes less than 1.5 minutes with this EO2. And oxygen delivery rate, even when we tested very low rates, was not predictive of kidney injury. So our conclusions are that a pressure drop of more than 40% for about 20 minutes puts the patient at a 60% of risk of having kidney injury postoperatively. And if the drop is of more than 50%, it makes it 5 minutes of 5 minutes of more than 50% drop is already dangerous and puts the patient at risk of kidney injury. So we believe that not only it is important to maintain DO2 on bypass, but it's also important to maintain a perfusion pressure above 60% of what is a normal pressure for age. Of course, this work was not perfect. Patients which were the most severe, which has no urine output during bypass, could not be analyzed. What we consider normal pressure was derived from literature in healthy children, and nobody knows if this is the best pressure for a child with cardiac disease. And finally, DO2 was only analyzed during cross-clamping because we didn't use a monitoring system for a cardiac output. So in fact, we only considered bypass flow as to calculate the DO2. Thank you.